Harvey Reiser, trained at Duke and Wills Eye Hospital, having come from Duke Medical School. Been in practice now, coming up on the 34th year. It's a long time. Was very interested in premium lenses, right with the very first 3M design many years ago, and followed it through and got involved. Was involved in many studies for lenses that were developed for use. And I implant probably 60% of people or more are premium upgrades. I started using it when we did an investigational study for the company many years ago, and the lens performed beautifully. It was great. And started to use it then. Of course, it wasn't FDA approved, so we couldn't use it clinically. And in that study, I think I implanted about 40 lenses. And then since that time, since it received FDA approval, in another post-market study, we're using it. And now it's a big part of my practice for presbyopia corrections for patients. So it's probably my current favorite lens that I use. It doesn't have a lot of parts to it, so it's set up to be on, in this case, a hydrophilic platform, which I know for many surgeons that's a concern because in the past there were some lenses and some hydrophilic designs that were such that there was calcifications of the lens. This lens, I believe there's 7 to 8 million implanted abroad as well as now in the US. And of that, the calcification rate, which is only on the surface, not right through the lens, is less than 0.0003 amount. So I think it's excellent. And then with that, it makes me feel comfortable to use the lens in patients. I think you have to be a little careful if you're going to put it in someone who you expect to have to do other procedures to, perhaps a DMEC and other things. So you want it to be in, like many patients, in a healthy eye. I think the key, it's always been my thought, is the simpler the design, the better for the patient and for the surgeon. So the ClearView is ingenious because it is so simple. It's you have 2 refractive zones, one that's for distance and one that's for near, separated by a single line. And as long as that implant centers on the pupil and the pupil is such that the lens is centrated nicely, then the patient will get 2 images, one distance and one near. Because of that, and there's not any rings in the lens or too many things that are active in the lens, the patient's night vision is excellent, pretty close to a monofocal, which is a big worry for people that are using premium lenses for presbyopia. But they get excellent near. My experience has been it compares to others being very frequently 20/20 distance and a sharp 20/20 and 20/20 near. And I just think the lens looks great in the eye. So as a surgeon, when it looks good in the eye, we feel, I think we feel good. We like the way it looks, and I do. And the patients, there's not an adjustment period. There's not a long recovery period. It's just like using a nice monofocal, but it gives them distance and near. And there's not really much, they're almost like wondering, why am I asking these questions? Like, what are you talking about? If I ask them, how's your night job? It's fine, or how's your reading? Well, it's great. So they're wondering why I'm even almost asking that, rather than someone who maybe would say, yeah, I have these halos and things a little bit, but I'm getting by. It's not like that at all. It's very much like using a monofocal, but with the added benefit of near vision. It requires about a 2.75 millimeter incision, which is larger than some of us use. And with that, it goes in very easily. It's an easy insertion. I use a little Sinski to deliver it right where I want it to be, and not been an issue at all. So put the lens in, and then I orient it so that the near ad is in the inferior nasal part of the eye. So for a right eye, it would be at like 45 degrees. For a left eye, it would be at 135 degrees, where the line would split the image in the pupil. Is it critical? I don't think so. I mean, we're just making ourselves feel good because when we read, we look down and in, okay? But inside the eye, it shouldn't matter. So as long as it's splitting the pupil, it's fine, even if it accidentally ends up being in the superior part for the near area. I don't think it would matter at all. But I'm trying to orient it, like I said, inferior nasal in each eye for the near ad. I would say to them, the number one worry that I think surgeons are going to have is that it's on a hydrophilic platform. Otherwise, I don't think this lens would have anything that would stop someone from using it. And I would tell them to look into that history of that hydrophilic platform on this lens and understand what the concerns had been and where they are now with the new material. And with that, I would tell them to try it and put it next to any other lens. I know that this lens is going to compare well to any other currently allowed or approved lenses in the US right now, and it will probably outperform them in most instances. I see an exciting future. I think we're going to get, the goal is obviously to get a lens that can give us great quality distance and near reliably with no downside risk. We don't see that yet. There may be some coming. This is the closest I can see so far. Again, because it's so simple. It's got one line, so nighttime driving is great. It does require centration to be in the pupil. It doesn't have to be perfect in the pupil, but it has to split you must have the refractive splitting of distance and near in the pupil. I think we're going to move away from things like diffractive multifocals with a whole bunch of rings. That's going to fall off first. These lenses that have less parts to them are going to stay longer and be improved upon.